answer them at the end. And the reason I ask you to put them in the chat is we may answer them throughout the presentation. If there's something critical you need an answer right away, feel free. Please try. I have muted everybody when you have come in. Please try to keep yourself muted just so that other people can hear. It would be really helpful. So that being said, this is the Erie County Opioid Epidemic Task Force that you're seeing on your screen here. This particular group was developed by an executive order by the county executive. It is a legal body. It was developed in direct response to all of the deaths we were experiencing due to opioid overdoses, and they really escalated after the implementation of ISTOP in 2014. That is our prescription drug monitoring program. 2016 is when the task force was put in place. It was put in by Executive Order 14. There are 7 work groups. They are all voluntary. The first work group is law enforcement. It is run by Dan Ronaldo. He is our local drug investigation officer that is hired by HIDA. We are a high-intensity drug trafficking area because of our overdose deaths and our arrests. Second group is family and consumers. This particular group here is run by a mom who has lost a child. Deb Smith was formerly a probation officer here at the county. She's retired now. She's lost a son. We have a large group of family members that have lost loved ones, myself included. We talk about our families. We talk about our losses because this is how we break stigma. No one wants to be sick with this disease. And if you walk away with nothing today, I want you to walk away with the fact that no one woke up one day and said, I think I'll be a drug addict. That is no one's life plan. But once this disease affects someone, this is a chronic disease and you have it for the rest of your life. So just keep that in mind. Next work group. This is Barbara Burns. She's in the U.S. Attorney's Office, and they're doing community education. They've been working with the media to change the language of the disease of opiate use disorder, to use less stigmatizing language, to use less triggering pictures, things such as that. They've been working with our seniors on appropriate medication disposal. These are some of their recent projects. They've done a lot of community education events to get the message out there. Next group is the providers. The providers are the medical providers, the doctors. We learned a lot about this disease process at the beginning of the epidemic. This particular process we've never treated as a chronic disease. We treated people as bad people with bad behaviors. They're not bad people with bad behaviors. They're very sick people. When we treat them appropriately, we give them the right medications and the right wraparound support services, they're really successful. When we don't, they are not. So we had to learn this. This has always been housed in mental health. It was a problem, it was a behavior. This is a disease, a sickness, it's a chemical change in your body. So the doctors have changed things drastically. One thing they've changed is prescribing of legal opioids. We know today that 86% of people struggling with the disease of opiate use disorder, and that is what it is called, started with prescription opioids. Whether they were theirs or they were someone else's that gave them to them being well-meaning. We didn't know how addicting these particular products were for many, many years. OxyContin was promoted as a non-addictive opioid. It's probably one of the most addictive opioids out there. We didn't know how long that people could take these things before they became physically addicted and had the disease of opiate use disorder for the rest of their life. We do know these things today. We didn't know how much of the population had a predisposition. We know these also. So about 10 to 15% of the population has a genetic predisposition to the disease of opiate use disorder. We don't know the gene. We don't know anything like that people are talking about. What we do know, we know that if you have a family history of alcoholism, you have a family history of clinical obesity, you have a family history of serious gambling, like you're losing your house. We're not talking about doing the scratch-off tickets here. That person, I probably would never order an opioid for. 10 to 15% of the population fits that criteria. And that particular individual only needs to take these products for 3 to 5 days to have the disease of opiate use disorder for the rest of their life. So a lot of things we didn't know, we know them today. The doctors have changed prescribing. They have changed how we address people, how we interact people, how we identify problems, how we treat pain. Pain is a symptom that something is going wrong. It's not the end all be all, so we have to look underneath. Dr. Lynch is the director of the pre-hospital program. That's emergency departments. We have a very robust program in Western New York. It is called Buffalo Matters. You can access medication-assisted treatment and linkage to long-term care at any emergency department in Western New York under the Matters program. You go in there, we have trained doctors to become what's called X-waivered, so they're able to prescribe buprenorphine. They will assess the person for medical eligibility. They will give them a 2-week script of Suboxone. Suboxone is a brand name, buprenorphine generic. And they will also give them a linkage to a long-term care provider within that 2-week period where this person is going to be connected for good. This is really key. You cannot wait with this disease process, so we had to work on that. This particular program is going statewide as of August 15th. My group is the Naloxone Access Group, and we really have changed what we're doing drastically, particularly with COVID. We'll talk a little bit about that. People have done what we wanted them to do in our community. They're great. They're staying home. They're doing what they need to do. But this brought a whole new compendium of problems for us. People are isolated. There's nobody there when overdoses occur. There are opioids and drugs that we didn't expect, stimulants like cocaine, all these problems. So we've had to learn. Mike Rainey was formerly the Commissioner of Mental Health here in Erie County. He's now retired. Mark O'Brien is the new commissioner. They have transitioned nicely. They oversee the treatment provider group in collaboration with John Grieco and Julie Gutowski from Spectrum Health Services. They have changed in the treatment world. Now, this is the Department of Mental Health, much different than the Department of Health. In the treatment world, they've changed how you access care. It is no longer about being, quote, clean. It is no longer being, detoxed. This is about putting people on the correct medications and supporting them. So, United States of America here. We have 4.5% of the population, and I'm going to give you some numbers, and this will put in perspective our epidemic. 4.5% of the population in the U.S., yet we write 80% of the world's OxyContin prescriptions and 90% of the world's opioid prescriptions overall. That's why we're in trouble today. We are a country of wealth. We're a country of we want it when we want it, and we got in a whole boatload of trouble with this. Pulling this in a little further so you can see it better, we in Erie County, we're looking very much like Appalachia, which is what we looked at as the epicenter of this epidemic. And then originally we're not like them at all, but actually we are. Very physical professions. People got hurt. We had good prescription plans. People did a lot of self-medicating. There wasn't a lot of checks and balances between people purchasing scripts at the pharmacy and knowing where they were going. This has all changed now. In New York State, our law is called ISTOP. It was put in place in 2014. It is a prescription drug monitoring program. In this program, when a provider orders something, it is an online program. There's no more paper scripts or electronic scripts. They look at the individual's information in there. It's not just about ordering a script. So if that individual has already had an opioid script in the past month, they shouldn't get another one. This is being monitored. So people that were doctor shopping and getting 8, 10, 12 scripts are down to 1. They're really sick. We didn't understand that. We put all these things in place, but we didn't have the back end in place. So now we do a lot of opiate overdose prevention training, which is what we're going to talk about today. What you see on this picture here is Narcan. It is brand name material. It is a 4 milligram unit each one. It's a nasal spray. This is what I will mail to you at the end of the training if you send me an email. So what happened? I'll tell you what happened. ISTOP happened. And when ISTOP happened, we were not prepared for the plethora of people that were on prescription opioids that no longer got them. We're also not prepared for the fact that this is a chronic disease. This is not a choice. People could not just stop taking them. That 10 to 15% of the population's brains had changed, their chemical production had changed, their receptor sites had changed, and just cutting them off at the knees did not work. They were seeking anything to feel okay. The disease of opiate use disorder is not about having a party, folks. It's about maintaining. Initially, when you take an opioid, you feel good, and that's a one-time thing. Opioids are not about repairing things. They're not about pain management. They're about making you feel good so you don't care about the other things. It's a one-shot deal. People don't get that same feeling again. So people didn't get that, and they're trying to feel good and taking more and more. 10 to 15% of the population will never attain that feeling, but they will go through withdrawal without it. Withdrawal, the creepy crawlies, like you want to rip your skin off. Diarrhea, vomiting, your head hurts, your hair hurts, like you cannot function. And this happens to people quickly, within 24 to 72 hours. They are very, very sick without these. And this is what happened to us in 2014, and we started to lose people. They were purchasing pills on the street. They couldn't get them anymore. They transferred to little bags of dope. You have to understand, opiates are opiates. Heroin is the original opiate. It's a natural, comes from a poppy. We have taken that drug, that molecule, we've gone into a lab, and we've created opioids. Opioids are synthetic opiates. Okay, so we have to keep that in mind. The Good Samaritan Law, that's critical. The signs and symptoms of an opiate overdose. ESAP and SCP, this is syringe access and disposal and drug disposal. 86% of people struggling with opiate use disorder today started with scripts. Let's get rid of the extra ones out of the house. We are burning about a ton of old medications from our kiosk system here in Erie County every month. And then we're going to talk about Narcan to reverse an overdose. Narcan is a brand name. Naloxone is a generic name. And if you do use it, I want to know what happened. We have learned so much about the epidemic from people reporting Narcan use, from law enforcement, families, friends, any first responder. So this is data from our medical examiner's office. This is the latest data for you. Currently in Erie County, and this is 2020, we have 44 confirmed cases of overdoses attributed to opioids in their system. This is through toxicology screens. Autopsies have been completed. The toxins have come back. There's 127 still pending. That means we don't have the toxicologies back yet. All of those will not be due to opioids, I will tell you right up front, but we don't rule them out until we're 100% sure. So looking at this chart, 2012, 2013, about 100 deaths. That was the OxyContin bump. It was when people were getting lots and lots of scripts. If I were to go backwards to, say, 2009 in Erie County, we always experienced around 70, 75 deaths attributed to some type of opioids. We had a bump after that in the hundreds. 2014, we went up to 127 deaths. This is a huge jump, but we didn't catch it quick enough. We didn't get these results till almost 2015, and it was due to the toxins. There were so many new drugs out there, they weren't even being identified. 2016, the number doubled, 256 deaths. 2017, 301 deaths. It was incredible. Now realize we're a county of just under 1 million people. Looking at that, and this is only Erie County, we're experiencing almost a death a day. So then we went on to 2017. Now this is a year after the task force came together. Those 7 work groups were all voluntary. They redirected resources that they had. We changed how you access care. We changed how things were paid for. We did all kinds of stuff. We trained a lot of doctors. We brought a lot of medical physicians into the mix. We worked with primary care, families, and we had a 17% increase in deaths. Following year, we continued on the same trajectory, huge decrease, down to 191. Next year, last year, amazing, we had 156 confirmed deaths due to opioid overdoses. Then we hit 2020. 2020, COVID hit, and things are a little bit different. And I'll show you some other information. We're very aware, and we are actively reaching out to people. We're looking at different ways to reach people and get them linked to care. So this is a very male disease, as you can see, consistently, 7 years running now. It is 3 to 1 male. These are people that have died that we've lost. This hasn't changed, and it makes sense. We've done some interviews with people and how people started taking opioids. A lot of it is sports injuries, profession-driven. And when you think of the types of sports and professions you get hurt in, a lot of them are male-attributed. Many females, though, too. My background, I am a nurse by trade. I have a degree in social work from many, many years ago. But in my nursing world, I'm an older nurse. I don't remember a nurse without a back injury. Really don't. We didn't have tools to transfer people, to move them. We just did it. And you got hurt and you continued to work. So think of this type of profession. Medical professionals, EMS, fire, police, construction workers, anybody that's a really physical job. Injuries occurred, and we were really pretty free with pills around here up until I stopped. People entered this disease, and they were really sick once they couldn't get the pills. We looked at this by race and ethnicity. Consistently now for 7 years running, it has been pretty much replicable of our demographics of Erie County. I want to caution you for 2020. That is a point in time. That is not representative of everybody that is overdosed. That is the 44 people we have been able to get the toxicology screens completed for. So I'm taking that as a point in time. This is not indicating racial or ethnic disparities. It's indicating that was what was completed at that time. And I want you to be aware of this because in this particular disease process, we're really trying to like pigeonhole people. Like it's those people, it's those people. In Erie County, it's all people. I don't care if you're green with yellow polka dots. Look at this data. It affects everyone. More affluent, the better prescription plans you had, probably the best entrance into the disease you had. Erie County is approximately 80% white, 12% black, 7% Hispanic, and if you look at this along the road, it's been pretty close right along the way. We looked at ages. This is very, very disturbing. For the past 5-6 years, our average age of death has been a 38-year-old male specifically. And this has been average, and we have really been tracking it. It's not who we expected. Everybody's about the children. It's not the children we're seeing. This year in 2020, extremely disturbing. It is much, much older. Our average age of death has increased. The 44 that we've confirmed already, as you can see, they are in the older age groups. The younger ones, the pendings, are going to fall out the same. It's much older. We're not sure why, but we are really trying to reach out to people, loved ones, families, friends. I don't really know. Reach out to them, make sure they're okay, do a welfare check, even if you're not sure. So this is those statistics to show you them. Consistently, that 20 to 39-year-old group has been a standout. I mean, if you look at that, it's about 25% of our population, but it's been about 50 to 60% of our overdoses. This year, it is not. If you look at 2020, it's only about 34%. What we are seeing is that much older age group. That is not good. So we need to pay attention here. Different messaging to different populations. This particular one is by residence at time of death. I'm going to show it to you a different way also. But we break it out this way to show you that it doesn't really change much. City of Buffalo, and I will caution you on 2020, this is a small subset of what we've seen this year, so I'm not comfortable sharing this. Every year has been very similar. When we look at this, it's about a third the city of Buffalo, 2/3 everywhere else. If there is a disparity, I would say it's the rural communities. That's an awful lot of overdoses that are occurring there for a very few amount of people. Erie County has a large geographic rural area, but a lot of people do not live there. The majority of our people live in the urban areas, City of Buffalo and first ring suburbs. So we looked at types of opioids that people were dying from. I'm going to show you this in a different format also, but I wanted to show you the latest data I had. Fentanyl is our killer here. This is our killer. Fentanyl is not the legal type. Fentanyl is an analog of the legal stuff. It's white powder. We know it comes out of China. Most of it comes through the dark web. It's coming in people's mailboxes. It's cut into everything. This is the most disturbing thing, and I want you to share this far and wide with your colleagues, your patients, with everyone. Stimulants are cut with fentanyl, and this is where we are seeing a huge increase in deaths, as you can see. About 45% of our deaths that we have our toxins back in 2020, about 42% in 2019, were attributed to a combination of cocaine and fentanyl. Cocaine is a stimulant. People do not expect this. They have no tolerance whatsoever. We've interviewed people, many people that use cocaine do not consider themselves a drug user. They're like, oh, I just did a little bump in the bathroom when I was out. And then they don't touch it again for months. But the problem with this is it's cut with fentanyl, there's no tolerance, and they're dead. We had a large incident in North Tonawanda. It's been about 2 months now. It was on Oliver Street. 4 individuals came home. They bought a bag of what they thought was cocaine. They all snorted lines of it. They saw it there on the table the next day. Problem was, one gentleman woke up at 8:30 in the morning the next day. Everyone else was dead. Different places in the apartment. When they did do the toxes, it was cocaine and fentanyl, strictly cocaine and fentanyl. People don't know what it is. They have no idea. So, I mean, really share this. This is this year's suspected overdose and overdose death. Okay, so I want you to be aware of this. This is from law enforcement. We work on a program called ODMAP where they report all overdoses. And they also report all deaths. And we've been tracking together to get suspected so we can reach out to families, to friends, to really try to help them. So looking at January and February, it is what I expected. Our numbers were down. The lethality was down. January, there is a seasonality to this disease around holiday time, so I did expect January a little more. February, right on target. March, if we looked at the beginning of March, up until March 13th, we were right on target. March 16th, everything shut down for COVID. And you can see what happened. The overdoses occurred at the same rate I expected, but the lethality was up there. We weren't reaching people. We were finding them alone at home. We were finding them in single-family homes. They lived alone. They weren't in their traditional places. Historically, overdoses, we find people, they're in public places. They're at work, on lunch, in an outhouse. They are at the drugstore, in the parking lot. They're in a fast food restaurant, in the parking lot, in a bathroom. This are at home. We asked people to go home and isolate, and they did. But they isolated and they died. Many people did. April, May, June look the same. The number of overdoses is not surprising to us. The lethality is. So we've put many programs and messaging out there. There's Never Use Alone. It's a number we ask people to call, no matter what they use, non-judgmental. Someone will ask them a little bit of information, like, where are you? What's the phone number? If I don't hear from you in 5 minutes, and send an EMS. They hear from the person in 5 minutes, they delete all their information. A way to keep people alive. There's a Text for Narcan program to get it right in people's hands. Families, friends, loved ones will mail it to you. Anything we can do to break down the barriers. So here is that residence at time of death, a different way to show you. Here's 2014, and if you're from the Western New York area, you'll understand this. This is our suburbs, every town, every village, rural, every town, every village. 2015, 2016, 2017, and there's 17, 18, and 19. Very disturbing. Doesn't change, looks pretty similar. It's about a third to a half city of Buffalo, and it's about 2/3 everywhere else. We ourselves were like, oh, city of Buffalo, it's what we expect. West side of Buffalo, what we expect. That's where opioids are traditionally used, sold. They're still sold there, not used there by the residents, by other people. Really disturbing. So when we mapped this out and we looked at 5 years worth, not what we expected at all. The zip codes that are lighter, like 201, 211, 214, 208, 204, 213, I would expect to be black, are not. This is our historical drug use areas. Where is everybody using when you look at the full map, not just to pull out of the city of Buffalo? Everywhere. There is not a town or a village that is untouched. Here it is by quintile, because everybody sees a little differently. This was even more apparent to us. We looked at the first 3 months of this year. This is just a straight map of the first 3 months of this year. Everywhere in the county. There is not a place that this is untouched. There's overdoses that have occurred everywhere. There is a concentration in the city and first-ring suburbs. I would expect that. That's where people live, and that's where people gather. People were in their homes. Really sad. So what did they die from? 2014, prescription drugs. That's the year iStop went in place. About half the deaths were attributed to prescription drugs. That's other opioids. Fentanyl started to come on the scene. Heroin was there. 2015, prescription drugs are getting down there. The law is doing what we wanted. We want to limit them. We did not take into account how sick people were. What took over was fentanyl. What we have learned from this, the drug cartels are businessmen. They saw an opportunity here and they flooded our market with a very cheap, very potent product. Comes out of China, like I said. If you're familiar with the dark web, you can go on the dark web, order it, it'll come in your mailbox. So here's 2016 and 2017. And there's 18 and 19. It's pretty much all fentanyl, folks. Straight fentanyl related, it's about half in 2019, but then when we look at it, it's about 3/4 because it's cut into everything. So we looked at Central Police Services to find out if they were seeing the same thing at crime scenes that we were seeing in people's toxes after they died, and they were. So this is Central Police Services. 2014, they were seeing heroin, started to see fentanyl. By 2017, it was all fentanyl. 2018, all fentanyl. And here's 2019. The other part that we have to be aware of, this is all polysubstance. These drug dealers are not rocket scientists, and these people, they're just putting anything in there. And then it comes here. So looking at this, yes, we have heroin, but then we have all of these combinations. That 53% is comprised of 65 different drug combinations, and it's not one substance. On average, it's 4 or 5. So a little historical perspective, heroin's been around forever. It was a product of the Bayer Company. Before we had Bayer aspirin, we had Bayer heroin. The Harrison Narcotics Act in 1914 is what got heroin as a Schedule 1. It's where scheduled drugs came from. At that point, Bayer's product became aspirin. I just want to share this with you because this is not new. This has been around a long, long time. Now, heroin is natural. It comes from a poppy. You grow a poppy field, you manage it, you do something in a lab to create opium, you go to heroin. It has a potency level that ends. It's natural. The synthetics, we can make in a lab. They're very cheap, and they're very fast, and they're very strong. So this is, if you want to know what it looks like, what fentanyl looks like. The top right is a kilo of pure butyryl fentanyl. This was from a domestic incident in South Buffalo. It was on Folger Street, actually. It was in 2014. At the very beginning of it ended 2013. One sister came from out of town to visit the other. That's one of her pieces of luggage up there. They were arguing, I guess, when the husband came home from work who lived there. He called the police to get the visitor out, and all this came to the door. This is how these things were happening then. Since then, the dark web has really taken over. But that what you see there, those are bricks of fentanyl wrapped up. In the top right, that is a kilo of fentanyl. That's what it looks like. On the very bottom, it's kind of tan. It's tan powder. In the gentleman's one open hand, those are individual bags. That is how this is sold. No one's walking up to anybody on the street and say, you want to buy a bag of heroin? What they're going to say is, you want to buy a bag of dope? You want Manteca, Cinco Dolore. That is the word for it on the street. What I did is I sold you a bag of dope for $5. Those little bags are marked. The drug dealers mark their product because, people want something that is strong. The gentleman's two hands together, those are bundles of bags. Those are called bundles. 10 of them together, and why they buy them like that, economies of scale. These little bags are so tiny because this fentanyl stuff is really, really potent, folks. There's no Ziploc baggies full of powder here. The equivalent of 3 to 5 grains of salt. So think about how much that is. That is all it takes to kill a non-opioid user of fentanyl. And this is butyryl fentanyl here, what we're seeing. This is drug mess in the community today. You'll see it everywhere. I take pictures. This is a throughway exit. And I put this up here because there's a lot on here that can be helpful to you to understand what's happening with people. The first picture is a picture of the whole thing. The two to the right are pullouts of that. So we'll look at the middle picture. On that board there, it's a cooker board. On there, those 2 silver discs, those are bottoms of pop cans. They're there because you can put a little bit of liquid in them because they're concave, and you put your powder in them. You can dissolve it by heating it up, and then you can draw it up in a syringe, or if you look at our far right picture around the pop can bottle at the bottom and at the top, quite a few tampons around there. You can put that liquid on a tampon. You can put it in a body cavity. This disease, the way it steals your brain, I'm not an IV drug user. I'm just taking medicine because I got to feel okay. This is what happens to people. Open bags in that middle picture, to go back to it, they look like open pieces of paper. That is a bag that has been opened up. It's folded up kind of like dentine gum. The material is very much like parchment paper. It's called glassine. This is the amounts of heroin, fentanyl, and carfentanil that it would take to kill someone, to show you the comparison. Heroin's kind of a wimpy drug. I mean, it's a natural. It's kind of wimpy. These other ones are made in labs. We control the potency. And they're also made very fast and very cheap. So heroin's expensive. It's about $80,000 a kilo, I've learned. But the fentanyls, and the middle one there, that is called butyryl fentanyl. It's an analog. It's an analog that is not even in the scheduled drug listing because it didn't exist. 3 to 5 grains of that will kill you. It's about 50 times stronger than the heroin on the street, about 100 times stronger than morphine, to put it in perspective. The far right vial is called carfentanil. This is actually a scheduled drug, but it is a zoological drug. This is not for people. This is a surgical drug for elephants, rhinoceroses. I mean, that could be thousands of times stronger than the fentanyl or the heroin. This is what we were seeing in the Appalachia area at the beginning of the epidemic. We're not seeing it as much anymore. Couple reasons why. When I work with law enforcement, they've made it make sense. That is a scheduled drug. If you're caught with that, you're going to jail. Those middle ones, they don't exist, these analogs. So until we can figure out how to get them on the schedule, they don't exist, so there's nothing chargeable. Now, in Erie County, we have a process. All of our police departments work together, and at the federal level, they've been able to put them on the schedule. They're able to charge people with them. So we're a little unique here compared to other communities. So you're all going to be trained overdose responders, and as such, you do need a refresher every couple of years. Best thing I can tell you, medications change, drugs change, responses change, and it's really helpful to get an update on what's out there. Your key job here, whether you're in your office, you're driving down the street, you're at home, if you think you see an overdose, call 911. We need to get our system moving to get that person some help. When you do call, let them know what you think it is. Use the words. Tell them, I'm using Naloxone. Naloxone is a generic name of Narcan. I need more. Tell them what's going on. And then if you do use Narcan, I want to know what happened. So who overdoses? Well, among opioid users, it's usually someone that's been using for 5 to 10 years. They have some experience. They think they know what they're doing. After they go to rehab. By the way, rehab without medication is not successful. The evidence shows this. Rehab can be extremely successful, but we need the right medications and the right support. Medication-assisted treatment is critical, and why I bring this up, after incarceration, our jail does not provide medicines to people. They take them off their medicine. So if you have a loved one, a friend, or a family member, and they were on medication-assisted treatment, such as Suboxone or Methadone, when they get out of jail, I'd be standing at the door with them to get them back on their meds. They've been detoxed, and they're very sick. Prescription drug users, they transition. They're buying drugs on the street. They're buying them on the dark web. Our older population, really creative. They know how to gamble on the dark web. Now they figured out how to buy drugs. So how does an overdose happen? Well, generally you have a little bit of time. We'll use Lortab as an example because they are still out there. People still take them. They still self-medicate. And it does not matter if it's a bag of dope on the street or a Lortab from the drugstore. Overdoses happen the same way. You take something, I don't care what it is. It gets into your blood system, it's in your mouth, you metabolize it, it's in your blood, it's now getting on the correct receptor sites, and you're getting the therapeutic effect. Well, if you take too much, that's an overdose. So we'll go through how that happens. I've been taking 2 5 mil, I'm going to make this up, a scenario for you. This is how many people get into trouble. Hurt my knee at work. I tore it up, I twisted it. It's probably the meniscus. I went to the emergency department. They told me to see a surgeon. I did. I went to the ortho. When I was at the emergency department, by the way, they gave me a script for Lortab, to control that pain. 2 5 milligram every 4 hours, as I needed them. They put PRN. Well, I am the general public. I don't know what PRN means, so I'm setting my alarm clock. I'm taking them every 4 hours. Working pretty good. I did go see the surgeon. They recommended surgery. I don't have time for this, and you're going to hear this from your patients. I don't got time right now. I can't take off, all this kind of stuff. So now I'm going to continue to take medication. The surgeon's like, okay, I'll give you another script till you're ready. Problem is with opioids, the longer you take them, you start to develop a tolerance. It happens to everybody. And with this tolerance, what happens is you develop more mu receptors, more of them erupt. Those are your opioid receptor sites in your body. We all have natural opioids in our body. It is our dopamine serotonin mix, our pleasure center mix. When we take outside opioids, we are learning a couple things happen. One, over time, you will get more receptor sites. So you develop a tolerance. It's your body's protective factor saying, I'm not going to let something happen to you. There's more spots for this to land, it's longer, it takes long. Other things that happen, and we're just learning now. Human body's remarkably lazy. If it does not have to create its own chemicals and to put them out, it's not going to do it. So you're putting in an outside chemical, and your body's like, oh, heck no, you're giving it to me instead. Medication-assisted treatment, the point of that is to fill those receptor sites so that they're not always craving, and that takes over your whole life. So that people feel like you and I do every day. Opiate use disorder and treatment is not about getting high. It is about functionality. It's about not being sick, not having diarrhea. So just try to keep that in mind. So I took my Lortabs. I took them 2 weeks, not working so good. Guess what? I'm gonna take 4 of those 5 milligram Lortabs. It is just flat out too much. I took so much that I filled all my receptor sites once it got into my system, and my extra's floating around in my bloodstream. Now, as I metabolize it or use it up off of those opioid receptor sites, those mu receptors, that extra just keeps going on. On the outside, what you're seeing, I'm not breathing. I'm making all these gurgly noises. I'm non-responsive. That's an overdose. So opioids repress the urge to breathe. They decrease your response to carbon dioxide, and that leads to respiratory depression, and you die. That is the continuum. Slowed breathing, breathing stops, your heart stops. Now, this cascade takes a little while. Human brain is pretty gosh darn amazing, but if it is without oxygen for 4 to 6 minutes, which is where we are when the heart stops, it's not coming back. This cascade is different than a heart attack. If it was a cardiac event, that would start, the initiation would be the heart stopping. We can restart your heart. We can use the AED at the end of this cascade, but we need to have oxygen in there. Otherwise, it's not going to work. So, overdose signs and symptoms. Couple scenarios here, a couple stages. One is heavy, uncontrollable nodding. When you see someone like this, it is pretty unmistakable. You're talking to somebody, and in the middle of a word, all of a sudden their chin hits their chest, and they're like, ugh. And you're like, hey, you just fell out. They're like, no, I didn't. They'll sit up and they'll say that to you, and you're like, I just saw that. I know I saw that. And if you confront them, they'll be like, no, really, I didn't. Believe your eyes. Know you saw what you saw. When someone is nodding out, they truly believe they're doing the right thing. That's one scenario. Another scenario, you may hear, like a mumble. That person is still responding to you, even though it's not, language you can understand. They're still responsive. In their mind, they've just told you, I am perfectly fine. What is your problem? That person wouldn't be able to give them Narcan, even though it's like that, because they're still responsive. The difference in an overdose and the nod is the lack of responsiveness. In an overdose, that person can still be gurgling and making noises, but it happens quickly. Skin changes, lack of oxygen, fatal overdose is death. But the difference here is one is arousable, one is not. Majority of overdoses are witnessed. This provides an opportunity for intervene. Who's calling for help today? Friends, family, employer. Once again, this has not changed. Fear of police, prevent people from calling 911. That is that Good Samaritan law. You're not going to get in trouble. We'll go over all the words there. Witnesses try and screwball the ineffectual things. Let me tell you what does not work. Please do not give your friend a shot of milk. I don't know where that came from. Fill up a syringe with milk and, give you a shot. Make your own saline solution out of table salt and water. Not sure where that came from, but that doesn't do anything. Do not put them in a tub of cold water. We see this regularly. How do we know? They show up at the emergency department completely soaked, completely closed. I know where you were. They weren't breathing. Please don't drown them. Please. The only thing that works is Narcan. This is the most popular thing right now, and we finally figured out, I guess it came from a Netflix special, putting ice in people's armpits and underwear. It does not do anything but make something cold and shrink. It does not reverse an overdose. So people need to be aware of this. The worst thing that someone can do is just leave them. If you're going to leave somebody, just call 911. It's okay. So Narcan in action. It's an opioid antagonist. It reverses an opioid overdose, comes in multiple formats, injectable, intranasal. Actually, it's available over the counter in all 4 formats. It just depends on what your prescription plan pays for. You do not need a script to purchase it, but it will be covered by your plan. You can go to any drugstore, say, hey, can you run my card, see what it's covered, and you only pay your copay. If you do not want to pay your copay, the Department of Health has a program called NCAP that will pay up to a $40 copay. If all of this is too prohibitive, call me and I'll mail you Narcan. There's no question asked. So it has a higher affinity to the opioid receptors than most opioids. According to the manufacturer, and I have to share this with you, it's supposed to last 30 to 90 minutes. It lasts about 15. So how does it work? All those receptor sites that were full of opioids that we talked about, with that Lortab overdose. I came on this person, they weren't responding anymore. I gave them a shake. Nothing happened. Next thing I did with them is I gave them what's called a sternal rub. I rubbed really hard with my knuckles on their sternum bone. Then I gave them Narcan because they didn't answer. Rescue breathing comes into play here also, but the Narcan itself gets in the bloodstream and it physically knocks the opioids off the receptor sites, those mu receptors, and it blocks them. When you give somebody Narcan, you put them in full-blown withdrawal. So I want to give you a heads up. You're not going to be making friends. You're going to learn new words. Just get a thick skin, let it all happen. It works on all opioids. I don't care what the news has said or police have. The problem was they weren't giving them enough. With our opioids out there, 2 to 3 doses is pretty usual. 2 to 3 doses of 4 milligram Narcan to reverse an overdose, but I have seen 5s and 6s. It depends on the strength of the opioid. And like I said, I want to stress, it does not last forever there. Because now we, loaded up everybody's receptor sites with Narcan, but all those opioids are still floating around their bloodstream. If those are long-acting ones, when the Narcan wears off, they're going to go back down. Call 911. Send them to the hospital. So Narcan in action, I shared a little bit with you. Sudden withdrawal. You're not going to make friends. They're going to get sick. I'll be honest, sick. About 50% of the reports I get have vomiting, projectile vomiting. We were thinking something was wrong. It's really attributable to the time of day. So look at the time of day with reversals. If you just ate lunch, lunch is coming out. There's no psychoactive effects. There's no potential for diversion. We give it away. EMS has used it forever. It's a rule out. There's no effect if an opioid isn't present. I have trained every law enforcement department in Western New York. They've all been afraid of it. I take Narcan at every training. I'm opiate naive. It tastes like crap, but it doesn't do anything for me. And they're just like, oh, it doesn't hurt you, is my point. Sold over the counter in New York State and almost every state in this country now without a prescription because this epidemic is so big. We've all been talking about COVID, but we continue to lose. And listen to this number, 191 people every day due to this epidemic. So, Narcan usage. I want to share this with you because this helped us learn about the epidemic. We didn't know a lot. I think we made things up. So, law enforcement and police, fire, EMS, been our keys here. I give them the Narcan. They report back what they did with it. So, looking at this, having about 2,500 reports, and we have way more now. This is by zip code where Narcan was administered. It's not about results. We were just looking for what was happening out there, and they were not zip codes that we anticipated. This is the time of day when Narcan was administered. It's pretty cyclical, has not changed a whole lot. It's around meal times, around shift work is what we're seeing. This is the day of the week, and this is probably the biggest eye-opener to us. Everybody's thinking everybody's out having a party. No, this is about functionality, folks. So if you look at this, the work week, it increases, increases, increases. Weekend is the low spot. And this is why I ask you to learn how to use Narcan and to use it. 93% of people get another chance. The disease of opiate use disorder has some crazy bad behaviors with it. These are not bad people. They're behaviors. When you get people into good treatment, they get on the right medications, those behaviors go away and the person is back. It's people trying to feel okay. My family, we have lost someone. I did tell you that I lost a sister to this disease. I raised her children. Did she want to be sick? No. When I was around her, the behaviors, did it seem like it? Absolutely, 100%. So we really just need to understand the person is there, the disease is causing them to behave in different ways than we expect. We get them in the right treatment, and medication-assisted treatment is what it is. The evidence today, and there are research studies, people need to be on medicine. Medicine is Suboxone or methadone. Vivitrol is third-line treatment. Vivitrol is naltrexone, long-acting Narcan. That's all that is. And actually, the latest study shows that people on Vivitrol are at a higher rate for overdose when they come off, so I wouldn't recommend it. Methadone and Suboxone, they're opioids. One is a full agonist, one's a partial agonist. You have to replace the chemical that is missing in that person's brain with the correct chemical. Otherwise, it's like giving somebody with diabetes a blood pressure pill and wondering why their glucose is off the charts. It's hard for people to understand. Medication-assisted treatment, you need to be on it a minimum of 2 years before you ever think of coming off it. Are people going to be on it for the rest of their lives? Absolutely. And that's okay. It's putting the chemical in their brain that needs to be there so that they're not craving and so that we're functioning normally. Do people go into this thinking about coming off it? It's probably the wrong thing to do. We don't start taking insulin thinking about when you're going to stop taking insulin. We start taking insulin thinking about how we're going to manage our disease. Same thing here. So we put a program in place with police. This is ODMAPing, this program here. We're all medical people here, medical. We are controlled by HIPAA. We can't share things. It's medical information. What I've learned, police can share anything. So we had people overdosing, and we had no way to figure out who it was because it was a medical event. I have peers in recovery that work with us here in the county. So working with the law enforcement program, those dots mean an overdose occurred. I reach out to that police department. They send me a police report. From the police report, there's a story there. There's contact information. And I should say on the other end, police leave a bag of resources at the incidents for us. They also distribute Narcan now. So with all this contact information, my peer here reaches out to those individuals 24 to 72 hours after an incident, not right away, and offers them linkage to care. We're pretty successful. So that bottom line on this chart here is after an overdose. About 22% of people connect to care. We follow them for 90 days. And I said we're pretty successful. In the world of substance use disorder treatment, this is amazing. People expect 3 to 4% of people to connect to care. I am medical. I think this is atrocious. I want everybody to connect to care. But I guess this is positive, so we're going to stay on track. The amazing number is that top line. Those are direct referrals by law enforcement officers, fire, anybody in their community. They identify people that they know are struggling from different incidents. For instance, law enforcement, how this occurred. They were at a domestic, and they knew the domestic was because people arguing about money because of substance use. So they put it out there and called us and said, can I send you somebody that I think might overdose? I said, sure, why not? This is that top line. These are direct referrals. And what we've learned here, 72% of people connect to care after a direct referral by someone that cares about them. That's what this is about. We follow up with them every 30 days for 90 days. They stay connected. Somebody reached out to them and said, I care about you. I don't want to find you dead. Please respond to this person and let's get you taken care of. It's amazing. So we've increased this project across Erie County, and we're really trying to increase it across the 8 counties of Western New York. Risk factors for overdose, to get back to the crazy stuff, using alone. Remember I said that never use alone during COVID? People are alone. Illness, depression, changes in the drug supply. iStop put a huge change on things. People transitioned from prescription drugs to street drugs. They thought they knew what they were doing. They're buying pills on the street. We're seeing a lot of fake pills on the street too. These are commonly used prescription opioids, and I wanted to put this out here for you because we have a couple overdoses every year, somebody under 5, and it's usually attributed to this. Children think these are candy, folks. And to children, they're very specific candy. I had a 5-year-old in a training. He told us that these were Pez, and he told us the flavors of Pez that they were. So they will see them, they'll get into them for anything. Narcan works on children. You have poison control's number at home, you call them, they walk you through saving your child. These drugs are out there, they're going to be used. There's a reason for them, so we just need to be safe. Oh, this is the opiate poppy. Everybody always wants to see what it is. Very pretty. Little gooey stuff on there, some opium coming out. There's a growing season. People have to man the fields. They have to do whatever they do with it to get opium to heroin, when they go in the lab. It's really, really expensive. And we think this is where the synthetics have come from. There's also a cap on the potency of heroin. It's natural. People are really sick. There is no end in sight to the development of those mu receptors. So the more opioids people take, the more receptors they get. So the heroin may not even meet their need. In review, in the first scenario, the heavy, uncontrollable nodding, they're still arousable. That person's like, whoa, gurgling away, but you're giving them a shake and you do that sternal rub and they're still responding to you. It may not be real words, but they are responding. They can be drooling, they can be gurgling, but you give them a shake and they're like, okay, leave me alone. The overdose. The difference is the lack of responsiveness. You give them a shake, nothing. You do a sternal rub, nothing. They can still be gurgling, but they change color fast because there's no oxygen in there. Fatal overdose is death. When you have this situation, you have to act right away. These are your steps. You call 911, rescue breathing if you have the appropriate equipment, Narcan administration, and the recovery position. This is the type of Narcan I'm going to give you. It's intranasal Narcan. It is a 4 milligram unit. I want you to remember this routine I'm going to show you quickly, because if you remember this routine to use this Narcan, you will never do it wrong. Peel, place, press. And why I show you that. This is a one-piece pre-filled unit. Once you push that little button, it's gone. You can't stop it. If you press it before it is in that person's nose, like you opened it up and you just happen to press it, it's gone. Throw it out, open another one. Don't stress over it. This is what rescue breathing looks like, and I kept it separate. I want to caution you. In the time of COVID, we know this is an airborne disease. Unless you have the appropriate equipment, and I mean a good mask, I would not do this. Would I give them the medication? Absolutely, 100%. I don't have too many law enforcement that do rescue breathing, and they have saved so many lives. Give them the medicine. If you have a mask, do rescue breathing, but I'm cautioning you with COVID, get an ambu bag. So these are your steps. I came on an overdose. I gave that person a shake. Oh my gosh, they didn't respond. I did a sternal rub. I got nothing. I called 911. I need a cart with Narcan. I think I got an overdose here. Now this is what I'm going to do. I'm going to yank that person flat on their back. I'm going to get their neck extended. Make sure it's nice and long and they get a nice clear airway. You want it extended because you're going to squirt that Narcan in their nose and you want it to stay right there in their sinus cavity. In their sinus, it's going to absorb through that mucous membrane and it's get on those mu receptors. So I'm going to get them on their back. I'm going to get that neck up. I'm going to give them a couple of breaths and I'm going to squirt a vial of Narcan in one nostril. If I do not have a mask, I'm just going to Narcan. Now this is the hardest part. They're on their back. I got to watch them for 2 whole minutes. You got to give that Narcan a little bit of time to absorb. If nothing happens in 2 minutes, open another one, but put it in the other nostril, squirt it in. Once again, if you have a mask, you can continue rescue breathing in that time. If you don't, please do not protect yourself. Now, this person's laying flat on their back. Just leave them there. Don't be holding somebody down. Don't be in their face. Just leave them there. When they come back, you're going to hear like a little cough usually. You're going to see the chest rise. When you see that happen, as quickly as you can, roll them over in the recovery position. Prop them up. You do not have to hold them. Key here, make sure that neck is extended out there because they're probably going to get sick. You're going to learn new words at this point. They're going to be rocking and rolling. They're probably going to lose some other body fluids. They don't feel good. They really don't. I just want to tell you that. Try to be patient, get a thick skin. We've done a research study. We just published it, actually, of people that have been reversed with Narcan in the past year. We interviewed 35 people. A couple themes came through every single interview. It's in the Journal of Substance Abuse. It was just published, and I can put that link out there. 2 themes. 1, Narcan reversal, folks, is not a life-changing event. It is a medical event. Something else changes behavior. This is very frustrating to people. They're like, you almost died. Like, yeah, it's a medical event. We have to work on other things for life-changing. The other thing is there's a time of kind of amnesia around these events. So you see that person the next day after you worked really hard to keep them alive, and you're like, oh, hey, what was going on? What were you thinking of? And they're like, who are you? They mean, who are you? Because they have absolutely no idea. So please try not to get frustrated. This is detox. This is what it is. Nausea, vomiting, diarrhea, your heart's racing, your blood pressure goes up because you're dehydrated. The other part I did not bring up, if you have any other substances in your body, they're there. It lowers your seizure threshold, everything, because you feel miserable. But all of this pales, compared to not breathing. Can you give them Narcan if you're not sure what they took? Absolutely, 100%. How about if it's a street drug or a prescription drug? Opioids are opioids, really doesn't matter. So what if we give to somebody who's not overdosing on an opiate? I told you, I've taken so much of it, you're never going to hurt them. You're going to make their food taste yucky for the rest of the day. That's about it. Here's a Good Samaritan law in New York State. It's a 911 Good Samaritan law. This was actually put in place and advocated for by the parents of underage drinkers because of hazing incidents on college campuses. Covers two people: a person who in good faith seeks health care for someone who is experiencing a drug or alcohol overdose or other life-threatening medical emergency, and the person who is experiencing the event. So if there's a big old party, everybody else get lost. These two people stay there. You're covered for having drugs up to an A2 felony offense. It's a lot of drugs. I can't even wrap my head around it. Alcohol for underage drinkers, any kind of marijuana, paraphernalia, sharing of drugs. You're not going to be charged with any of this. So don't be afraid to help somebody. Say there's a syringe there. You're not going to be protected if there's this huge, huge amount of drugs, which is probably a drug dealer. You're not going to be there. Or, and this we need to share with people, if someone has a warrant, they need to take care of their business. It doesn't go away. So some nuts and bolts of Narcan. Needs to be kept at basic room temperature. Don't make yourself crazy. I would not keep it in the car. There's a new product that actually is coming out like this week from the Narcan company. It has a red plunger instead of a white one. It is much more temperature sensitive on the freezing end. The problem with this freezing is there's a little glass vial in the unit, and that's what the liquid medication is in. And when that liquid freezes, the vial breaks. I'll tell you from experience, it was in my car. So with them putting whatever they're putting in the base, it's keeping it from freezing. It is much more. On the high end, we really don't worry too much. There is an expiration date there. It's usually about 2 years out. If you have an expired kit, put it in the background, keep it as a backup, but get fresh Narcan. They're doing studies at the University of Iowa and the University of, Illinois also, Waterloo, of temperature sensitivity and expiration date. Adapt Pharma is also, it looks like the Adapt Pharma version, tentatively, we're looking at like 5 years out. So just keep it as a backup. Make sure you have stuff that is within parameters, but we use more than 2 doses of Narcan on most reversals, so you're probably going to need it. This is text for Narcan, folks. Please share this far and wide. We will respond within 24 hours. We will put Narcan in the mail to you and any information that you need to connect to care. Gets in the mail. People generally get their Narcan within 24 to 48 hours. And I brought this up before. Please share. We are having a huge issue. As you saw, 45% of our deaths last year were attributed to a combination of cocaine and fentanyl. Narcan works on fentanyl, works great. But people that are taking cocaine are like, I'm not taking opioids, I don't need Narcan. They do. Please share this information. And that's why we do this. I just want to introduce you to Antonio. This is one of the peers that works with me here. He's been in recovery for 21 years. Amazing man. I've known him since the day he entered recovery. Family, children, has helped more people. And this is what people don't understand. This is people you work with every day. We talk about our families, our loved ones, and understanding. You're going to have patients. Don't be afraid to ask them questions. Don't be afraid to tell them that there's alternatives for pain management when they come to you and they're like, well, I got my tooth out. I need OxyContin. Maybe an ice pack would work. All of these things. This is my team here at the health department. You can contact any one of us at any time. We're willing to do trainings for folks. We will link people to care. If you know somebody's struggling, they need to connect to a peer, anytime, feel free. At this point, I'm going to open up the chat. Let's see here. Okay. If you have any questions at all, now's the time, jump in. My email is here, cheryl.moore@erie.gov. I need you to all do that now to send me an email with your mailing address, and I will mail you Narcan a certificate of completion. Does anybody have any questions? Okay. Yes, if they are nodding, you do not need to administer Narcan at that point. I wouldn't leave them. I'll be honest with you. I wouldn't leave them. I would, someone had asked a question, if they're nodding, to not administer. Not at that point, and to be honest with you, you probably wouldn't be able to. That's a real motivator with somebody that's overdosed before. They will do anything to try to get up. Because giving them Narcan, they're going to go in full-blown withdrawal. It's really hard, though. So if you see somebody on a street corner, just call 911. I see somebody nodding. You need to send by a car with Narcan. If a car drives by for police, That's all well and good and they're gone. That's okay. That's their job to drive around the neighborhood. If they're still there, they'll save their life. Thank you for asking. Great question. Anything else? All right, folks. Thank you so much for taking this training. I will look for your emails. I see 91 of you signed in. You all have my email now. Cheryl.moore@erie.gov. There's 2 L's in Cheryl. Make sure you get that in there. And we'll pop them in the mail to you. Have a wonderful day. I will post the recording. Take care.